Welcome to Health Yeah, where experts from Stony Brook Medicine come together to discuss topics ranging from the complex inner workings of an infectious disease to tips and tricks for staying safe and healthy all year long.
Welcome to Health Yeah. I'm Dr. Julie Leanne, Associate Professor of Gynecology at Stony Brook Medicine and Division Director of Minimally Invasive and Robotic Surgery. Today, we're talking about something millions of women experience but are told far too often is normal, and that's heavy bleeding and pelvic pain. Heavy bleeding that disrupts your life shouldn't be dismissed, and that goes for pelvic pain too. Whether it's pain with your period, pain during sex, or chronic pain that just doesn't seem to go away, it deserves our attention. In this episode, I'm joined by two of my colleagues, Dr. Sarah Kim and Dr. Caitlin Waters, surgeons from our minimally invasive gynecologic surgery team, also known as MIGS. We are OB/GYN physicians who specialize in diagnosing complex gynecologic conditions and offer advanced patient-centered treatment. Today, we'll unpack what's normal, what's not, and when it's time to seek care. Most importantly, we'll talk about how women can advocate for themselves and the treatment options available today. Let's get into it. So, Dr. Kim, what does a normal menstrual cycle look like? How much bleeding is too much?
Generally speaking, a menstrual cycle frequency is about anywhere from 21 to 35 days. It kind of varies by individuals and the bleeding could last anywhere from 5 to 7 days. Normally, if you really want to quantify, if you look at papers, they will say it's about 2 to 3 tablespoons. Is considered normal. Anything greater than 80 milliliters is considered heavy. Personally, even for me, I find that kind of hard to quantify. So I usually tell my patients, hey, if you're bleeding through a super tampon or a pad, more than one pad an hour, that's considered too much.
Okay. And what are some symptoms that would be red flags or to suggest that the bleeding is too heavy?
So most symptoms are what we consider like signs of anemia, that your actually blood level is a little bit too low. So if you're like fatigued, dizziness, shortness of breath, I think those are really red flags. But even if they don't have those red flags, if the bleeding is bothersome, I usually say, hey, come in for an evaluation for us to kind of assess what's going on.
Okay. And Dr. Waters, at what point should patients seek care?
If patients are experiencing frequent periods, prolonged periods, or heavy periods, they should come in and seek care. But also one that's often forgotten is if patients are also skipping periods regularly, it would also be a good idea to come in as well.
Okay. And what are some common causes of heavy periods?
So some benign causes of heavy periods can be fibroids, endometrial polyps, adenomyosis. Patients can also have irregular bleeding from PCOS. Sometimes you can have genetic conditions that can cause periods to be heavier. And then a non-benign condition would be a cancer of the uterus. So that's something we take pretty seriously.
So a lot of things to think about then.
Absolutely.
For patients. And how do women find out if they have any of these mentioned conditions?
I would say come look for us because first and foremost, a history and physical exam is very important. So we would ask patients what their symptoms are like, how long they've been having those symptoms. And then we would do a physical examination where we could, if someone has a big fibroid uterus, we could actually feel that on an exam. And then our best friend is actually an ultrasound. So that would give us a little closer examination to look at the actual uterus to see if there's fibroids, polyps, things that Dr. Waters kind of talked about. And we're able to kind of assess for other structural causes like adenomyosis as well.
What I find sometimes interesting is that with the sort of advent, let's say, of social media, I think a lot of our patients are seeing what's normal and what's not normal because sometimes they don't really talk about it with their family members or their friends, or sometimes they do, and then that's when they realize, oh, what I'm experiencing isn't normal. And other times patients I talk to them and they have really heavy bleeding to the point where they are, let's say, passing out, and they never said anything because they thought that was their normal. So right. I think certainly if you're ever concerned, I think patients should definitely bring up their symptoms to their doctors.
I agree.
So, Dr. Waters, is a cause of heavy or irregular bleeding always identified?
That is such an important question, and the answer is unfortunately no. We don't always identify why a patient might be having heavy or irregular bleeding. That being said, we still take the symptoms very seriously, and patients should be counseled on all of the medical, procedural, and surgical options that we have available. My hope is that as more research is put into women's health, the percentage of times we don't know the answer to the bleeding will decrease with time.
Right. I think the positive is that even if we don't necessarily know the cause of the bleeding, there are still options that we could use to help our patients.
Right. And again, taking them seriously and offering them the options that we have at our disposal. And how can we evaluate for possible endometrial cancer?
So oftentimes patients may come ask, I have irregular bleeding. So is that something that's going to be a red flag for something? So we usually say, hey, one of the things that we do a part of the workup is to rule out cancer because endometrial cancers can present with irregular period. In the reproductive age female, it could be irregular bleeding, irregular menstrual cycles. In a postmenopausal female, it could be just postmenopausal bleeding in general. So we rule endometrial cancer out by actually doing a biopsy in the office. We basically put a little pipette, which is like a little straw inside your uterus, obtain some cells, and then we then send that off for pathology.
Right. So I think besides assessing for some structural or non-structural causes, we also make sure that, something more, something serious like precancer, the cancer of the uterus, isn't the cause of the heavy or irregular bleeding as well.
Right.
So let's dive a little bit deeper into one of the more common causes of heavy bleeding, which are fibroids. So Dr. Kim, what are fibroids and how common are they?
So fibroids are benign. They're smooth muscle growths on the uterus. It's very common, actually. So I think a lot of women find it surprising when they learn that they have fibroids, but about 60 to 75% of reproductive age females actually have fibroids. Sometimes it's incidentally found when we're doing an ultrasound for some other reason, during pregnancy sometimes. But during the workup for heavy bleeding, oftentimes fibroids could also be found.
Right. Are all fibroids treated the same? And what factors might influence which treatment options are available to a patient?
I think the biggest thing that goes into what options and how to treat fibroids are usually patient symptoms. So one of the things that patients ask, like, hey, I have this, 1 centimeter fibroid that they found incidentally. Do I have to do something with it? And I always say, hey, if you have no symptoms from it, then not necessarily. And then the next step is, the size and location also kind of dictates what kind of treatment options are available. So depending on how big it is, whether or not we could actually remove it with small incisions, minimally invasive. We also could sometimes remove fibroids like vaginally. Again, so the location and size matters as well as symptoms. Right. And not everything is always surgical. So we could also have medical management options as well. So again, based on their symptoms, is what we offer patients and kind of have a discussion about the options.
Right. Dr. Waters, what are some of the medical options that are available to treat fibroids and heavy bleeding?
So starting with over-the-counter options, NSAIDs, ibuprofen, can actually decrease not just the pain associated with bleeding from fibroids, but also the amount of bleeding, which is something that patients also often find surprising. In terms of non-hormonal but prescription medications, one of the ones we use a lot would be tranexamic acid, which is a pill that you can take 5 days a month when you're bleeding from your period, but you can only take it 5 days a month, so it's a bit limited. Then we get into our hormonal options, which do make up the bulk of the medical management treatment options for fibroids. There are hormonal options that have both progesterone and estrogen, like the classic birth control pill. But for patients who are not candidates for estrogen, which is a fair number of our patients, there are also a lot of progesterone-only options that we can use to safely stop the bleeding.
Okay.
And I'd still want to put a plug for like marine IUDs is another
great
option
point.
That depending again size and location, if you have a fibroid in the cavity, you may not be a candidate for an IUD. But if it's more in the wall of the uterus,
right,
what we call intramural fibroids, and you still have heavy bleeding, that is something that we could use as an option to help with the bleeding.
Right. And each option comes with the associated benefits and risks as well. And so I think having that detailed discussion with your doctor, but depending on what your workup, your physical exam, your ultrasound shows, will then ultimately help tailor your treatment.
Absolutely.
What about a holistic approach to treatment of heavy bleeding? Let's say, someone is a little concerned about what they've read and heard online about hormonal options.
So that's a question we're getting more and more often from our patients. I think an important point to make is that because the menstrual cycle is driven by fluctuations in hormone levels, which bring on a period, that's often the way in which we can treat bleeding. So the hormonal medications are particularly effective because they're really addressing the cause of menstruation or the cause of the irregular bleeding. I would say I've had a lot of patients come to see me hesitant about the use of hormones, and then they end up being willing to give that medication a try, and they end up being able to avoid invasive surgery with the use of the medication. So of course there's risks with any medication, but Ultimately, it's a good discussion for a patient to have in depth with their doctor. As for the question about some of the alternative or complementary modalities that you can use to treat bleeding, in this day with social media, patients are asking us more about those other methods. Unfortunately, there is a lot of misinformation on social media, and so we have to be really careful about parsing out what information is useful and correct and what information is potentially harmful.
Right.
So if you're wondering about a particular supplement, I would say please discuss it with your doctor.
Right. So I do think that while we have medications and treatments that can definitely help a lot with fibroids and bleeding, if someone does want to consider other options, complementary and supplemental options, then definitely speak to your doctor about the safety of those methods.
Right. I oftentimes get questions about if there's any dietary changes that they could make or exercising could shrink fibroids. I always tell patients there's no clear evidence, but I'm a big proponent of exercising and healthy lifestyle choices. So I say, why not? It'll make you feel better overall. So I think that's also something to consider that, hey, those changes are okay. Depending on, again, talk to your physician about it. If it's more for like overall healthier life choices.
Right. And I think there are some emerging research into certain things like vitamin D levels and other, let's say, green tea extracts that could potentially affect fibroid growth. Certainly, those are new data. I wouldn't necessarily recommend someone drink a lot of green tea to try to shrink their fibroids. But again, I do think there's growing research and looking into other methods to help. So what about some surgical options?
I'll first talk about some of the minor surgical options that we have. One of the things is embolization. So you could have uterine artery embolization or uterine fiber embolization. That is basically decreasing the blood flow. So we would send a referral to interventional radiologists. So as gynecologists, we don't necessarily do the embolization, but interventional radiologists will see you as a consult and we'll kind of discuss the procedure, which again is more of kind of decreasing the blood flow to the fibroids. So then over time, the fibroids will shrink and die. Another thing that is relatively new, but we do actually offer at Stony Brook is called a sonata ablation. So that is using radio frequency waves and to basically char the fibroid. It's kind of burning the fibroid and to kind of preventing it from getting any bigger, shrinking it. It has been shown to be very successful. Again, we do offer that at Stony Brook Hospital. And a lot of patients have found it very favorable because the downtime from the ablation is actually very minimal. And you usually don't wake up with any type of abdominal incision. It's all done vaginally. And then if you have kind of, like I said, a location of the fibroid that's intercavitary, again, a vaginal approach where you could introduce a hysteroscope, which is it's basically a camera inside the uterus, and then use a shaver to kind of resect and shave down the fibroid. So those are kind of the minor procedure options that we have.
Right. And then these are all things that we offer at Stony Brook.
Yep.
And Dr. Waters, any other procedures that patients can think about?
So once we've tried medical management or the procedural management options, then we move on to sort of some of the larger surgical management options. And those are typically myomectomy or hysterectomy. Myomectomy meaning we remove the fibroids, hysterectomy meaning we remove the uterus. And I think a really important point to make is that when we do a hysterectomy to remove fibroids in a premenopausal patient, a patient who has not yet gone through menopause, we don't need to remove the ovaries. And so patients will not necessarily be put into menopause from a hysterectomy. I think that's a common point of confusion. And so it's nice to have the opportunity to clarify that. In terms of treatment options, myomectomy versus hysterectomy, that's best a discussion that patients have with their surgeon to figure out what surgical management option is the best. Regardless of whether a patient's undergoing a myomectomy or hysterectomy, we always opt for a minimally invasive approach where possible, meaning we would opt to use small incisions if feasible instead of a larger incision.
Right. So Dr. Waters, can you tell me about a recent success story?
Speaking generally, I see quite a few patients like this patient, but younger patients will come and they will tell me that a previous doctor recommended an open hysterectomy, and then we review the imaging. I talk to the patient about what they're interested in, and we find that we can do a myomectomy, and not just a myomectomy, but with a minimally invasive approach. Typically, we opt for a robotic-assisted laparoscopic myomectomy, and patients tend to do very well with that, and they're really pleased to have heard about expanded options, and so usually very successful.
Right. So again, definitely a discussion to have with your doctor and then possible referral to a minimally invasive GYN surgeon if needed. So let's switch gears a little bit and talk about another big topic that we see a lot as gynecologists in the office, and that's pelvic pain. It's a lot of times patients talk about or complain about their pelvic pain and then their doctor tells them it's normal. It's part of their menstrual cycle. So how do we know when pain isn't normal?
So again, come look for us. So history physical exam is crucial, differentiating different causes of pelvic pain and how to address it. So if it is gynecologic related, one of the first things we ask is, hey, is it something always related to your menstrual cycle? Is it cyclical? Is it related to something? What other symptoms do you have? Do you have pain with intercourse? Do you also have pain with urination? Do you have pain with bowel movements? Then we kind of start thinking about other systems that may potentially be involved. If it's cyclical, then we get, again, more in the line of gynecology just because patients in our population have menstrual cycles every month. If it's not cyclical, then we start thinking about, okay, maybe it's more the bladder related and not really us, and maybe the uterus and the pelvis is more of like a bystander. So one of the things that we, again, do is more of like a history and physical exam, really kind of gives us more answers. And again, then we do refer patients for an ultrasound to see if there are any anatomic causes of the bleeding, not bleeding, but pain that they have.
Mm-hmm. So I think one of the key things is to take your patient's complaint seriously. And I think, again, pain to the point where someone may be missing work or school or events of their life and it's affecting their quality of life should always be taken seriously. And that's not normal. So sometimes pain, as Dr. Kim said, isn't associated with your menses. What are some possible conditions that may cause pain outside of periods?
One of the most common causes of pelvic pain that is not cyclic would be something called high-tone pelvic floor dysfunction. And we treat this a lot in our chronic pelvic pain clinic here at Stony Brook. But this is essentially when the muscles of the pelvic floor are persistently tight and they don't relax normally. Patients can experience pain with intercourse, pain at the time of the speculum exam, at their gynecology visit, or chronic pain unrelated to those conditions. And it's really important to have an exam done by a qualified provider who's familiar with the exam and the assessment. One, I want to make a plug that if any patient is experiencing any type of sexual dysfunction, that they should talk to their doctor about it. I think a lot of times patients can be nervous, but if you're having pain, especially with intercourse, we are here to support you through that and talk about options. And then if we do find high-tone pelvic floor dysfunction, the treatment is primarily pelvic floor physical therapy, which can be very effective and has minimal risk. And if patients don't respond to that, sometimes we consider trigger point injections to help as well.
Right. So I think similar to bleeding, again, these are topics that some people might find embarrassing, but, certainly if it's affecting their quality of life, something very important to talk about with your gynecologist. And then hopefully if they can counsel you on the options or refer you to someone like our team to help you with their symptoms. Yeah. So let's dive a little bit deeper into another hot topic, which is endometriosis. That's a condition that one of the big causes or main causes of painful periods. So, Dr. Kim, what is endometriosis and why do you think it's such a hot topic these days?
So endometriosis, one of the ways that I explain to patients is kind of like retrograde menstruation. So meaning that technically during normal menstrual cycles, blood is kind of supposed to flow out of the uterus. But what starts happening is that you're almost like menstruating into your pelvis. So whether it's into your ovaries, into the peritoneum, which is like the tissue surrounding your pelvis. So it creates a chronic inflammatory condition inside your pelvis. So it's almost like a hostile environment. So every time you have a period, it creates a lot of inflammation and pain. It's irritating all the nerves around it and the tissue around it. Over time, some patients will start then developing non-cyclical pain because as now there's so much scar tissue and inflammation surrounding the pelvis, even outside of the menstrual cycles, those tissue is completely inflamed. So they may start feeling pain more and more outside of the menstrual cycles, and then pain with intercourse. So those are all things that kind of start to inflame the overall pelvic floor, and that is what endometriosis is. Reason why it's a pretty hot topic is, one, it's a very common cause of pelvic pain, but two, it takes time to diagnose it. So the average time to diagnose endometriosis is about 7 to 10 years. And part of it being that most women do experience some menstrual cramping. So oftentimes it gets ignored as, hey, this is just part of your menstrual cramping. Just take some NSAIDs or take some birth control pills and it will go away. And while those are actually treatment options for endometriosis, if patients really do have endometriosis, the pain could be very debilitating and affect their quality of life. But if it gets ignored and just more what we saw like pills could be kind of thrown patients' way. And so patients may think, okay, well, if it's that common, maybe this is just normal. Everyone else has everyone else has pelvic pain or menstrual cramping. This is just part of being a woman, and then kind of go on ignore for a long time until they actually talk to a provider, and then they start describing their symptoms, and then they're missing school or work. And then now we know, okay, maybe this is more than just pelvic, just mild menstrual cramping. This could be more extensive, like endometriosis.
Right. I think, you mentioned the delay in diagnosis, 7-10 years. It doesn't take 7-10 years to diagnose it. I just think, unfortunately, women go through multiple doctors, different specialties to figure out why they're having pain. And then, as you said, sometimes, frequently, it does involve other systems too, besides just, GYN. So they can have associated bladder dysfunction, GI dysfunction, amongst other systems. So it's endometriosis, just similar to fibroids. I think that definitely needs more research, looking into, what's causing it. We don't really know the cause of endometriosis and other treatment options. So yeah, it definitely deserves more research.
I think part of the delay is also the fact that the true way to really diagnose endometriosis is surgically done. So that may be another reason why there might be a little bit of a delay.
Right. So if someone comes to you and with pelvic pain, painful periods, and you're suspicious of endometriosis, what's the workup like?
A history is going to be really important here. And if someone says that they have pain with their periods, the discussion about possible endometriosis should really be coming up at that first visit, that that's a possible cause of their pain. So a very thorough history, a physical exam, and then ultrasound is really a cornerstone for us in terms of evaluating endometriosis. And here in the GYN department at Stony Brook, we have dedicated ultrasound to evaluate specifically for endometriosis, in particular something called a sliding sign. So we do a little bit more advanced ultrasound here for endometriosis. Sometimes an MRI may also be helpful, particularly when you're trying to evaluate for endometriosis affecting the bowel or bladder. That may be a little bit more difficult to pick up on ultrasound. And then in terms of definitively diagnosing endometriosis, as Dr. Kim mentioned, surgery is the definitive diagnosis. You can see endometriosis lesions. Sometimes they can be clearly identified on pathology. But also we can sometimes see endometriosis from imaging alone. So we don't always necessarily need surgery for that diagnosis. And more importantly, because surgery has risks and we know that endometriosis is primarily managed medically, a lot of times if a patient does respond well to the medical management treatments for endometriosis, to us that's a sign that yes, perhaps they do have endometriosis. So response to presumed treatment, even without surgery, can give us a lot of information.
Right. What are some of the medical treatments then?
Yeah, so some of the medical treatments options are like hormonal intervention, because endometriosis is hormonally driven. So birth control pills is usually our first go-to because the side effect profile is a bit less. A lot of patients could tolerate it. And you could, whether it's estrogen-containing birth control pills or progestin-only birth control pills, those are also options. We also have a little bit more dedicated endometriosis medicines like elagolix or Lupron. So they are more acting on, the best way to say it is kind of putting the body into medical menopause. So temporarily kind of shutting off your ovaries, because again, endometriosis is hormonally driven, making sure that you're not menstruating. So then the idea being that if you shut off your ovaries and you're in menopause, the endometriosis pain should subside.
Right. I mean, these are, the different options to someone hearing that, putting me into a medical menopause, that just sounds very, scary and very severe. Again, these are options that we discuss with patients. Doesn't mean that, this is the, we highly recommend one versus the other, but it's again, shared decision-making that we review with our patients. Right. Besides medications, are there any, you mentioned surgery. So what is the role of surgery then for endometriosis?
So surgery for endometriosis can be effective in a number of situations. One, if a patient has, let's say, a very large cyst on their ovary or very significant findings on imaging. It can be effective for patients who are struggling with infertility. Sometimes the fertility specialist will refer those patients to us to see if there's any visible endometriosis that we can remove.
Right.
And then sometimes when patients are further along and they're done with childbearing, sometimes they request a hysterectomy. But something to discuss is there are limitations of surgery as well. So in particular, let's say we were to perform a hysterectomy, but we were to leave the ovaries. Unfortunately, that would not be definitive treatment for endometriosis because, as Dr. Kim mentioned, it's chronic, it's inflammatory, it's hormonally driven. So if you still have your ovaries, you can still have cyclical pain even without a uterus. And that's a very hard concept for patients to sort of wrap their mind around because it's so unusual. Usually, we can use surgery to fix something completely, and endometriosis is a little bit different from that. Something to consider, especially for fertility patients, is sometimes we see a small cyst on the ovary, but if we perform surgery to remove that cyst, it can have negative effects on fertility if the ovarian tissue is compromised. So it's a really close back and forth discussion with your surgeon, with your fertility specialist about if surgery for endometriosis would be potentially helpful or harmful. And then the last thing to mention for surgery for endometriosis is that each subsequent surgery performed for endometriosis, unfortunately, we know has fewer and fewer improvements in pain following surgery, less significant improvements in pain. So we really try to save surgeries for endometriosis when it will provide the most benefit to the patient. And this is not a type of condition in which we recommend patients have repeated surgeries because the benefit to them is less and less with each subsequent
and then
surgery.
more risks with each subsequent surgery.
Right.
Yeah.
Right. Yeah, that's why sometimes when patients come in for pelvic pain and they're like, oh, I want my uterus out because I have pain, I always kind of circle back and say, okay, there's multiple reasons for the pain, and it may not necessarily, just taking the uterus out may not necessarily cure your overall pain.
Right. And you mentioned a good, you highlight another facet of endometriosis, that being impaired or difficulty with fertility. I think a lot of patients come refer to us from their fertility specialist because they have had trouble getting pregnant, failed different, IVF cycles. And so even if they're not symptomatic from, let's say, having painful periods, they may have silent, let's say, endometriosis, and that one can affect the main outcome is then impaired fertility.
Fertility, right.
That being said, patients with endometriosis can still get pregnant. As you know, we all encourage our patients, if they're not planning to have a pregnancy right now and they're not interested in pregnancy, to please use birth control.
Mm-hmm. Yes. Yeah. Yes. If surgery is done looking for endometriosis and let's say no endometriosis is seen, what are the next steps?
So if no endometriosis is seen at the time of surgery, which happens for us, first and foremost, I think a lot of reassurance needs to be given to the patient that their pain is certainly real, even if endometriosis isn't seen intraoperatively. And more importantly, that we're going to continue to take their pain seriously and treat it. So even if there's no endometriosis, we still have great treatment options for cyclical pelvic pain, related to a patient's period. And I think that's something we often discuss with patients before surgery to say, hey, there's always the possibility we don't see anything. We will be here to support you regardless.
Right. Another plug for seeing a minimally invasive GYN fellowship trained surgeon is that endometriosis has different appearances. And so, you should see someone who is well-versed in the different appearances of endometriosis, the best way to remove those lesions.
Right.
So Dr. Kim, what would you like to see happen in the world of endometriosis moving forward?
Overall, I would like to see more research and funding go into endometriosis and just generally speaking, pelvic pain for females. Again, just because it's become more normalized, I don't necessarily see a ton of research opportunities, kind of even clinical trials to try different medications. With that, seeing more treatment options, newer treatment options for patients. We've seen, the GnRH antagonist agonists, like the injections that kind of put you into medical menopause. Those are relatively newer, like the oral pills for it, but we haven't really seen anything come after that. And It's been many years since those pills came out. Yeah. So I would like to see additional treatment options. And then also just maybe other ways to kind of diagnose or kind of as a marker to diagnose endometriosis. Like we said, there's, imaging for us is very helpful. Ultrasound is helpful. MRI is helpful. But again, the gold standard oftentimes is to do surgery for official diagnosis. But if there is something that is less invasive where we could actually do blood work to assess for endometriosis, I think that would be very helpful.
Right. I think there's growing research coming out that endometriosis is maybe more immune system mediated. And, it's definitely affecting not just the GYN organs like the uterus and ovaries, but also bowel and bladder. So I think, yes, there is definitely more attention being paid to this condition that affects about 10% of women worldwide. But I do think, just like with other areas of women's health, a lot more research money needs to go into it. Yep. So we talked some about heavy bleeding and pelvic pain, endometriosis, and fibroids. We mentioned that we are minimally invasive gynecologic surgeons. What is minimally invasive gynecologic surgery?
So providers who specialize in MIGS typically have additional years of fellowship training, typically 2 to 3 years, dedicated to conditions such as endometriosis, chronic pelvic pain, and fibroids. And there's sort of two components to this. The first component is obviously surgical expertise. We know that high-volume surgeons tend to have fewer complications and better patient outcomes. So we're really trying to have patients receive the best care possible by doing this additional surgical training. But then the other piece is also the medical management. So especially for conditions like endometriosis, some of the medications that Dr. Kim mentioned are a little bit more complex. You can only use them for a certain duration of time. And so we specialize in managing these medical conditions as well. So when a patient has these issues and they see a provider, they can be given all of the options, medical, procedural, and surgical.
Right. And what are some benefits of minimally invasive surgery?
I would say some of it is cosmetic. And so you don't wake up with a big incision. Often our incisions, you might wake up with maybe 4 or 5 incisions. They're about 5 millimeters, which I always tell patients they're about the size of my pinky nail. And recovery is often much faster, so pain is less. Studies have shown that pain after minimally invasive surgery is less than an open approach. It's like a bigger incision on the abdomen. There's studies that also have shown that there's less blood loss, less infection complications. So overall benefit of minimally invasive surgery outweighs the open approach. However, I always tell patients there is a time and place for open approach. I think that's why you have to go to the right surgeon who could kind of offer you all those options, that is able to manage surgically all the complicated cases, whether it's open, whether it's minimally invasive, but has the skill set to offer you the option of minimally invasive as a potential.
Right. I would say in our world, most surgeries are able to be done minimally invasively, either through laparoscopy or robotically assisted laparoscopy. And so, again, going to a fellowship-trained surgeon, I think, is very important. So then, as Dr. Kim said, that doctor should be able to offer you the medical options and surgical options for your treatment, for your condition. Right. And when then should patients seek care from a MIGS specialist?
So we work with some really fantastic community OBGYNs in the area who know when to refer patients to us. So large fibroids, endometriosis, patients who need medical or surgical management, and chronic pelvic pain. We obviously see a lot of referrals for that particular group of patients. But sometimes, I would say to a patient who maybe isn't in this area, if you feel that the provider you're working with isn't offering you all the options, please don't hesitate to self-refer to a MIGS provider, because we're happy to see you and discuss all the options with you. And really, I think ultimately the takeaway is, if you're concerned about any of this or you want a second opinion, even amongst MIGS providers, we would encourage you to do so. The more information you have, the better decision you're able to make.
Right. I think frequently we'll see patients that were self-referred, or that their friends told them about their MIGS surgeon, and they'll say, my doctor told me I can only have this large incision, and frequently that's not the case. So as we said, but it's really important to advocate for yourself, know what's available in your community, and don't be afraid to speak up for yourself. If you're listening today and something you heard resonates with you, trust that instinct. Heavy bleeding or pelvic pain that disrupts your life is never normal. Those symptoms are worth paying attention to and worth discussing with your doctor. Our MIGS specialists are here to offer you the full spectrum of medical and surgical management options. Come chat with us. Thank you to our guests for sharing their expertise, and thank you for listening to Health Yeah. Please like and follow us for more great health information from Stony Brook Medicine.
Stony Brook Medicine is Long Island's premier academic medical center. We transform lives through scientific discovery, education, and care, and we bring together innovative research, advanced education, and extraordinary healthcare expertise to set the standard for how healthy communities thrive. For more information, visit stonybrookmedicine.edu or follow us on social media, Stony Brook Medicine on Instagram, Threads, Facebook, YouTube, and LinkedIn, and Stony Brook Med on X.